Organizers for this invitation. So I'm supposed to discuss today immunosignatures, their prognostic and predictive values in breast cancer. So this is the outline of my talk. So first of all, we'll discuss the immunosignatures and their again prognosis and prediction. Secondly, I say something about the tumor infiltrating lymphocytes, which probably are captured by these immunosignatures. Then I will show some new data regarding what are those cells and what do they present, and then I finish with some open questions which are under intensive investigation. All right, so first, immunosignatures and prognosis. So this was the first paper published by Calder's group a few years ago, that they demonstrated for the first time that an immune-related metagen can be associated with better prognosis in high-risk estrogen receptor-negative breast cancers, as you can see from this Kaplan-Meier curve on the right. But at the same time, we're also assessing different metagens and different signatures which recapitulate different pathways as well as the tumor microenvironment. And we also find that the STWAT1 metagen is again immune indifferent gamma-mediated signature was also associated with better outcome in high-risk estrogen receptor-negative and HER2-positive breast cancer. Many other investigators done similar work and similar analysis, and those are shown in this table, summarized in this table, showing that actually all those immune signatures were associated with better prognosis only in high-risk, high-proliferative, ER-negative, HER2-positive, or luminal B tumors, whereas we didn't find any signal in estrogen receptor-low proliferative luminal A breast cancer. What about now immune signatures and prediction? So this was a similar analysis that we have done now based on the neoadjuvant data. So patients were treated with anthracyclines and taxanes-based chemotherapies, and we asked the question whether any signatures recapitulating different molecular pathways and tumor microenvironment can improve, increase the pathological computer responses. And the results are here. If you combine all tumors or patients, you see that, of course, proliferation-driven signatures were associated with higher PCR rates. But also, as you can see, we found that immune signatures, at least the two ones that we have used in this study, were also associated with high PCR rates. And if you break down those patients according to the molecular subtypes, either triple-negative, HER2-positive, or luminal, we see that these immune signatures were highly associated with increased PCR in HER2-positive. This was really dramatic, as you can see here. Actually, the only biomarkers that were found to be associated with higher PCR rates were these two immune signatures, and also in triple-negative breast cancer, as you can see here. What about now tumor infiltrating lymphocytes? Can you use Beppe Viale's eyes under the microscope and just count for tumor infiltrating lymphocytes and see whether you can get similar results? So first of all, this was the first paper, as Fabrice mentioned before, from our German colleagues, that they hypothesized that increased numbers of lymphocytes in the tumor may increase no PCR rates, and this is what they demonstrated in two large neoadjuvant German trials. So you can see, for example, here, the overall PCR rates in one of those two trials was associated with about 12%, 30% of PCR, whether when we have more than 10% of lymphocytes, we increase the PCR rates to 30%, and for those tumors with what they call lymphocytic predominant breast cancer, which are those tumors that have more than 50% or 50% of intratumoral lymphocytes, they showed a really very, very high PCR rate. What about now those TILs and prognosis? And this is something that we have published recently. First of all, we wanted to address three questions. The first one, whether we can use these lymphocytes and see whether those lymphocytes can predict prognosis, as the signatures do. Number 2 were to see whether those TILs had a distinct prognostic value according to different molecular subtypes. And number 3, whether actually an immunogenic type of chemotherapy, in this case tetracyclines-containing regimen, could predict better response according to this lymphocytic infiltration. So here we looked for the big 298 study, where patients were randomized to receive either an tetracycline-only containing regimen or tetracycline and taxanes. So first of all, we found that there was association between tumor lymphocytic infiltration and molecular subtypes. We found that as for the signatures, a higher number of lymphocytic infiltration in HER2-positive and triple-negative breast cancer. And we did find also that those TILs were associated with better outcome in triple-negative breast cancer, not actually in the HER2-positive breast cancer. And for the third question, whether those TILs could predict the immunogenic type of chemotherapy benefit, actually we found that there was heterogeneity in terms of response of benefit according to the treatment. And this heterogeneity was found only within the HER2-positive tumors. Actually, those tumors, those HER2-amplified patients that received only an anthracycline-based chemotherapy, they did better than those that received anthracyclines and taxanes, and without having these increased numbers of lymphocytic infiltrating lymphocytes. What about now TILs and trastuzumab benefit, where this is very, very provocative results I'm going to show you. This was based on a very, very good collaboration that we have established with our colleagues from Finland, from the Finnish trial. So we were able to get all these tumor blocks and just assess and again count the number of lymphocytes in the tumor and the stroma and see whether this could be associated with a better outcome or better response to trastuzumab. And the answer is yes. Actually, we did find that only patients and tumors with high lymphocytic infiltration benefit from trastuzumab, whereas in patients without this lymphocytic infiltration apparently did not benefit from trastuzumab. Of course, these are small numbers and need further validation, but I think I found it very provocative. Now, to conclude for the first, regarding the first part of my talk, when you have this immune signal, either by using these immune signatures or just counting lymphocytes in the tumor, you have a better outcome, you have a better natural history of the disease. You may benefit from chemotherapy and you might benefit from trastuzumab, and this is true for high proliferative, high-risk patients, namely basal and HER2-positive tumors and maybe luminal Bs. Now, what do they present? I think this is an important question if you want to move forward. And this is something that I'm going to now present to you. Oops, can you move forward, please? So we have first to understand what is the current consensus regarding these lymphocytes and tumorigenesis. So there are two types of immune cells: the good guys, which include the CD8 cells and the matured dendritic cells, the natural killers, the macrophages, M1 type macrophages, and as well as the H1. And those are the good guys because they probably activate immune response and they have an anti-tumor immune response. And then you have the bad guys that includes the immature dendritic cells, the Tregs, and the M2 macrophages or Th2 cells that is considered, I mean, those cells may promote tumor growth. In our institute, we started with a great collaboration that I have with one of an immunologist from our institute. We started actually to interrogate what are those immune cells within the tumor. And from our first FACS analysis that we have performed, it showed two things. First of all, that the majority of those T cells in the tumor are CD4 T cells. And number two is that those CD4 cells seems to be higher in numbers in tumors as compared to the adjacent normal tissue. We have to know that these CD4 positive cells include several subtypes. Again, the good guys, the Th1, which has been shown to have play a role in cancer growth and reduce cancer growth. And then you have those bad guys, again, the Th2, the Th17 and Tregs that are supposed to suppress the immune response and therefore to promote tumor growth. And then you have the follicular helper cell that is nothing known in cancer in general, in breast cancer. So we wanted to address 4 questions here. Number 1, what are these T cells that infiltrate the breast cancers? What is the difference between tumors that they are defined as extensive versus minimally according to the number of infiltrating tumors, lymphocytes? What is the status of these lymphocytes? And is there any localization or organization within the tumors? So to address that, we, as I said, we isolated lymphocytes from tumors, and we performed some microarray experiments on those cells. Lymphocytes were isolated from the tumor, from a lymph node, and from peripheral blood, from the same patients. The first results from that analysis showed that those CD4 cells isolated from the tumors are very, very different as compared to those cells that isolated from the lymph nodes or from peripheral blood, as you can see from this unsupervised clustering analysis. Now, next we compare, this I'm going to show you, we compare the gene expression profiles that we have generated from those TILs isolated from the tumor, from lymph nodes, from peripheral blood, and from healthy donors, with the signatures that you can get from cells from lymphocytes that represent Th1, Th2, follicular helpers, Tregs, and Th17 cells. So this is shown here now. First of all, this is the heat map of that analysis. You can see that the signatures that you can get from the infiltrating lymphocytes from the tumor, it's very, very different from those generated from lymph nodes, peripheral blood, and healthy donor, number 1. And number 2, now if you compare these signatures with the signatures you can get from the Th1 cells, you can see that they are pretty much similar, meaning that those TILs may contain Th1 cells. Also, having done the same type of analysis, we found that it may also contain Th2 cells, because you can see again when you compare the TIL signature with the signature that you can get from a Th2 activation, they look pretty much similar. The same thing regarding Th17 cells, also for Treg cells, also for the follicular helper cells, as well as for memory cells. And the majority of those memory cells appears to be effector memory cells. So the first message from this analysis is that all major CD4 positive T cell subsets infiltrate human breast cancers. The second question, are any differences between lymphocytes that we isolated from extensive versus minimal infiltrated tumors? So again, we discussed several times of tumor heterogeneity, but I'm going to show you that there's also a huge heterogeneity regarding tumor microenvironment. There are some tumors that shows very high number of leukocytes and lymphocytes in the tumor, which we call extensively infiltrating tumors, and there are some other tumors with very, very few lymphocytes within the tumors, what we call minimally infiltrated tumors. So then what we did, we just compare the expression patterns from lymphocyte isolated from extensive versus minimal, and what we found is that for the extensive lymphocytic infiltrated tumors, the two messages that came out were that those TILs may contain majority the Th1 cells as well the T follicular helper cells. Actually, the gene that was on the top of that comparison was the 6L13, which is actually a very good surrogate marker for this follicular helper T cells. And we demonstrated that this chemokine, particular chemokine, is indeed expressed by the CD4 cells from extensive compared to the minimal infiltrating tumors, and this marker also is indeed expressed by lymphocytes and not by tumor cells. So the message number 2 is that TILs from extensively infiltrated tumors contain a higher frequency of follicular helper T cells and Th1 subsets compared to the minimal infiltrated tumors. And number 2 is that the 6L13, which is a key chemokine secreted by CD4 positive follicular helper cells, are found in extensively infiltrating tumors. The third question, what about now the status regarding of the activity of those cells? So I'm not going to go into the details. I just show you and summarize different experiments that we have done using tumor supernatant, etc. That number 1, when you compare the expression profiles from TILs isolated from a tumor compared to those isolated from peripheral blood or lymph nodes, yes, TILs are suppressed. They showed a reduction and reduced activation, immune activation. However, when you compare those lymphocytes from extensive compared to the minimal, well, we found that those cells seems to be less suppressed, or if you want, more activated. So the message number 3, though TILs in extensively infiltrated tumors are more activated and less suppressed by the tumor microenvironment. And the fourth question that I found very, very actually intriguing, and I was very surprised with these results, what about localization and organization? Well, by doing this comparison between extensive versus minimal, we found that in breast tumors, in those extensive infiltrating tumors, because we call tertiary lymphoid structure, which actually resembles very, very much to lymph nodes with their germinal centers. And if you're looking for the cellular composition of those lymphoid structure in these extensive infiltrating tumors, actually we found, as you know, all the T cells that you can find in lymph node structure, for example, the CD3 cells, CD4, CD8, the CD20, or which are B cells, the follicular dendritic cells in the germinal center, etc. So very, very, very impressive, and which now comes to my fourth, I think, important message, that an extensively infiltrated tumor contain a higher frequency of those lymphoid structure that may actually organize an immune response, which may actually be responsible for a sustained immune response. And this is the model that we think, maybe it's not true and needs some further validation, is that in those extensive lymphocytic tumors, there is, because of the presence of these C613 helper cells, you starting having this organization of the T cells into this structure, lymphoid structure, that may be responsible for the development of the memory cells that are those that may clear the microscopic cells in the bone marrow, for instance, that can explain the good natural history of those patients. And because of that, we are about to develop what we call the immunological grade, which contains two different components. The first one is the morphological immune score, which includes the TIL score as well as the TLS score, and combined with a molecular immune score that includes 8 genes that may capture in a better way this lymphoid structure. Now, we'll finish with several questions that I think are important to investigate in the future. The first one is why we see this structure only, for instance, in HER2-positive and triple-negative breast cancer. We don't have an idea. Maybe with this next generation sequencing analysis, we'll have some clues. What are the genetic and epigenetic alterations that drive the development of those lymphoid structure? What's the role of B lymphocytes? I show you that the follicular helper may actually induce B cell lymphocytes that may be actually important, and which patients actually will benefit from immune-related therapies, for example, vaccines or the ATP-D1, ATP-D1. Maybe actually we need to stratify those patients according to either TILs, or I think it's better based on their lymphoid structure. And with that, I will finish, and I would like to thank many people in my lab, my mentor, Martin Picard, Shreen Loy, which unfortunately left and went back to Australia for me, and of course, Karen Willard and the group in the immunological lab who was actually the initiator of the studies that I've just, the results of them just showed you. Thank you very much for your attention.